Yeah, I know. It's all right. You can never tell when a doctor's going to be busy or not. Okay, let me just hand over hosting to you so that you can share your screen. And there we go. You should be able to share your screen now.
Okay. So, hello, colleagues, doctors, ladies and gentlemen. Thank you for I feel quite privileged to actually do the presentation today. Look, it's a very topical conversation. I mean, we have been actually diagnosing adjustment disorder for years, and basically this is one of the commonest diagnoses that is basically seen in some of the medical legal reports, especially in work cover reports. And probably I thought that I would share my experience, and I'm happy to learn from all the participants who are there. I'm not saying that I'm fully equipped with everything that I need to know about adjustment disorder, but I found it a little bit more complex than just the DSM diagnosis which we use for legal benefits. Okay, so I'm a fellow of the college, and I'm a member of Faculty of Adult Psychiatry. I've done my membership from UK. Michelle has given enough, details, so we'll straight away jump into the topic. Okay, so we'll go to the first slide. I know my slide might look a little bit wordy, but I think when you are able to read it, it should be more easy. So I thought that it's important to analyze each and every symptom of DSM very carefully so that we can look closely and examine what adjustment disorder means and what could be the inclusions and exclusions and where are the gray areas. I'll go into the criterion, that's not capital, the section A of straight away, which is the development of emotion and behavioral symptoms in response to identifiable stressors which happen within 3 months. Now, each and every word in this one is important. So even though it's a very condensed line, it means a lot of things, which I will explain. And I will also mix it with my experience. So while what is written is very clearly that emotional and behavioral problems should occur within 3 months of the stressor, these actually present,
Sorry, sir, we can't see the slides. Can I get you to click on the share screen, the green button with the arrow? It'll either be at the bottom or the top of your screen.
Let's have a look.
It'll be within the Zoom menu, somewhere around.
Yes, I know. So
there you go.
Can everybody see that?
We can see a blank screen now, but there we go. Got it. Thank you, sir.
So
sorry to interrupt.
That was the first slide. It doesn't have much in it, except my name and the adjustment disorder. This is the first slide, actually.
Thank
the
you.
material element. So I'll read it again. Okay. So it is important to analyze each and every symptom of DSM-5 very carefully so that we can closely examine what adjustment disorder means and what could be the inclusions and exclusions and where are the gray areas. I'll go into the criterion A, not the capitalism is this thing, and straight away, which is the development of emotional and behavioral symptoms in response to identifiable stressors, which occur within 3 months of the onset of stresses. All right. While what is written in DSM very clearly is that emotional and behavioral symptoms should occur within 3 months of the stressor, what are the feelings that you expect in the patient? Patients would feel sad, they would feel hopeless, frequently crying, when feeling, worrying, anxious, the patient may have trouble sleeping, the patient may have lack of appetite, difficulty in concentrating, feeling overwhelmed, functioning in daily activities is affected, and withdrawing from social supports and avoiding things such as, doing simple things like paying bills. And sometimes suicidal thoughts and behaviors can be rife, and we'll discuss that in detail at a later point in time because it's important to actually identify suicidal thoughts and behavior along with adjustment disorders. And what's the problem and difficulty in identifying and not identifying them and how it presents. And what are the behavioral, emotional and behavioral responses we have discussed? What are the stressors that you see? There are about 43 stressors which are basically discussed in Bedford or in any of the social anxiety rating scales or social life stressor scales. Some of them could be actually divorce, relationship and interpersonal problems. Divorce has got the maximum weightage. Changes in situations such as retirement, having a baby, going away to school. Adverse situations like losing a job, loss of loved one, or having financial issues or problems in school, life, at work, or experience in physical assault, like we have got the army guys. I mean, physical assault, combat, natural disaster. We had three natural disasters. We had bushfire incident. I think I would not call COVID anything less than a national disaster. It has sort of wrecked the capital. If you look at the Royal Victorian Commission, it's full of two reasons why the Royal Victorian Commission of Mental Health came in. One of the reasons was COVID-19, and the second was bushfire. And we have recently experienced a huge amount of flooding in the southern part, and which has affected life. And Michelle, we were flooded in Townsville 2 years ago, and people have not yet recovered from it. It's 2022. People still have got grief, and I think there is a chronic adjustment disorder. So I'm just trying to bring about the realism of this illness in patients' day-to-day life and how people have been affected. People have taken part-time job, people have lost job, the work industry has been affected, hospital has been affected, the workforce here has been affected, army has been affected because army was called out and the people were stressed. So I think I'll just move on with the presentation instead of sort of getting dragged into, because otherwise we'll lose the objectivity. However, in cases where certain stresses, now this is important, where some stresses can be chronic. In cases where certain stresses are chronic and enduring, like relationship problems, interpersonal problems, loss of jobs, inability to get jobs, patient may not develop symptoms for weeks or even months of the diagnosis. Now, this is the gray area because the DSM actually says that symptoms should develop within 3 months of the stressor. Whereas in reality and clinical practice, it may not be the case. But where do you stand legally when you do the report? Because you have to say that legally it has started within 3 months of the stressor. So I think it should be left to the clinician's sort of decision that where is the line, and whether I should really consider those 3 months as a sort of bulletproof criteria. From a legal perspective, yes. But sometimes in chronic illnesses like cancer and chemotherapy and all those things are ever evolving, and the patient basically achieves a new normal, which I will discuss in a minute. We should also remember that some of the cognitive symptoms are not only about extreme helplessness, but about denial of existence of illness or handicap that is associated with stressor, or loss that the person has experienced. So everything about adjustment disorder is not loss, but sometimes patients may just deny that they have got a problem, and that could be an adjustment disorder. It could be denial that the person has got an issue at work. It could be a denial that the person has basically lost his limb and how it's going to actually affect it the rest of his life. It could be denial about a head injury and the kind of faculties which have been affected, including mood, cognition, depression, all those things, and may be difficult to engage. Okay. So behavioral problems can include social withdrawal, lack of care, irrational and non-adherence to treatment. That is important because sometimes patients with adjustment disorder will not accept treatment. They will not sort of play the ball and accept psychological or medication treatment from the clinician. So all these can qualify for emotional symptoms of adjustment disorder for satisfying the criteria, as I mentioned. Again, I'm sort of making that concluding sentence. We should always remember those 3 months emotional and behavioral symptoms, but in the context and the theory of all these things that we discuss. So it's not that simple. It's a bit complex than what we see. Now let's go into the criterion B. These symptoms or behaviors are clinically significant as evidenced by one or both of the following. So B1 is marked distress that is out of proportion to the severity of or intensity of the stressor, taking into account external context, cultural factors that might influence a symptom. It's important to know that cultural factors are something that is ignored, external context is ignored. I'll explain them with examples, and the severity of the presentation, and severe impairment in social, occupational, and other areas of functioning. I'll discuss this as well. Both these are gray zones again. So I'm now trying to evaluate criterion B, and this is based on my clinical experience and the read-ups that I've done over the years. Now we need to actually understand distinguishing factor between normal adjustment. A normal person can adjust as well, and the person may be suffering from adjustment disorder. Once you have given adjustment disorder, you have given 309 point something of DSM already to the patient. Okay, whether it's mood, anxiety, conduct, whatever. The first criterion is the symptoms are persisting beyond the time they might be attributable to the stressor. This judgment is relatively straightforward when the stressor is a single event. A single event is always easy to identify, and it's very easy, and it doesn't take a lot of effort, and even a psychiatric registrar can do it. But however, if the illness is protracted or the stressor is more persistent or intermittent, such as cancer, following intensive treatment or multiple sclerosis, it's less easy to judge and say where the illness began, where the illness is going to end. And in such cases, usually the delay in onset of adjustment disorder will also be seen. And I'm just sort of accumulating things from what I discussed in the first slide. Therefore, to simplify this, a concept of maladaptive behavior was used in the older DSM. I find that clinically very useful. This was in the older DSM, and it was assumed that disturbance will remit as soon as the stressor ceases, or the stressor persists, then a new level of adaptation is achieved. This is where, knowing the patient is very important. When you know what his new level of adaptation is at this point in time, and he has probably adapted to the chemotherapy, and probably the illness is stable and stationary, which we use all the time. We basically say that adjustment disorder is stable and stationary. That's what you're trying to say, that the patient has probably achieved. The patient may not go back to the pre-morbid level. Maybe it's not possible. The employer has changed, the illness has changed its course, the trauma has changed its course, and he may not ever return back to pre-morbid. But if he has reached a new level of adaptation, the illness is stable, and you would say that this is probably an exit point from work cover, work insurance, whatever is the patient's need, because of which he is under the diagnosis or under the requirement of an assessment for a psychiatric review. Therefore, what I use in my clinical practice is patient has reached a new normal, a new baseline after a period of chemotherapy. I'm giving you an example of liaison psychiatry. And I'm just going to move out a window. Okay. Chemotherapy after a period of treatment or after a period of rehab scenario. This is the commonest scenario that you will have in your private practices, where patients are in rehab processes, and they would be engaging with several clinicians, physio, hand therapists, occupational therapists, orthopedicians, psychologists, and have they reached the new normal? There are scales that you can do. You can use some Bedford scale, or you can use social adjustment scale, disorder scale, to see whether things has reached a baseline. But unfortunately, it's difficult for a psychiatrist to do it all by himself. He needs a team, because otherwise the person is really going to get exhausted. But from a legal perspective, the patient can come back and challenge you that I'm not normal, doctor. This is not normal. And the interest could be that the patient actually is trying to lose some of the benefits or gains that he might have achieved if that adjustment disorder continued and was not stable and stationary. So in order to make such bold decisions, it needs to be backed up that what you mean by new normal and what is expected in that condition, and how do you describe this? I think under the scenario is described towards the end, when a defense person has lost his limb after trauma and is able to function reasonably okay and has reached a baseline despite his handicap, and stable and stationary. So we'll go into the criterion B2. This is the trickiest one, and I find the impairment in social functioning actually very tricky. Even vocational functioning is sometimes tricky, and I'll explain why. This is because many cultures, illnesses are followed by a period of convalescence. I will repeat this. In many cultures, illnesses are followed by a period of convalescence during which the activity is reduced or a return to full social responsibilities is deliberately deferred, because it's a healing process for them. This may actually be a healthy avoidance of activity if it allows full recovery from the illness, but prolonged or protracted avoidance of activity may lead to secondary problems, like he can start having problems with his employer, he can become more phobic about his work, and there could be loss of role. The employer may just terminate his employment. So I think if the person is avoiding at the onset, it may not be actually classed as a sort of symptom adjustment disorder. Probably it's a healing process which has begun. This is again a gray zone, but protracted loss of social and vocational activity should be seen as a cause for concern, and there should be no clear duration criteria as to how long it should continue. Generally speaking, I would use the criteria of 6 months after complete remittance of stressor, which is a part of DSM, and if stressor continued, if a new normalcy was achieved. Also, one needs to actually understand sometimes social and vocational avoidance is healing and helps recuperate the patient rather than being a part of the pathology itself. It is difficult to ascertain how this needs to be judged in a day-to-day clinical practice. And generally speaking, most of the time we'll refer to the DSM criteria, where we feel that functioning has returned on not as a yardstick to understand if the illness is healed. Therefore, it's always a good idea to look at cluster deficits. Don't just look at social function deficit. Look at vocational, recreational, interpersonal, relationship, divorce, general interaction with friends, all those things. That should, if there's a global impairment, then probably you would say that yes, his condition has gone down. If the person is just being socially avoidant after work, that may be a normal process. That may be his way of coping. So criterion C is the stress-related disturbance does not meet criteria for another mental health disorder and is not clearly seen as exacerbation of pre-existing mental health disorder. Now, this is the easiest of the criteria. Unfortunately, what I see, Michelle, is in some of the reports, people have, I'm not blaming anybody. I mean, we are all learning. I'm learning, and I might learn at the end of the session. But one of the things that I've seen is that patient has got a pre-morbid diagnosis of PTSD, and the diagnosis has been made as adjustment disorder currently because of some work-related, this is superimposed on PTSD. That's an erroneous diagnosis. You cannot have it. So this is fairly straightforward, and differential of adjustment disorder from other psychiatric disorders is more straightforward because others have got clear criteria. Adjustment disorder is a bit vaguer, it's a bit vague or a bit foggy. The major conditions which are found in association with most stressors are depressive disorders. So if the patient has got clear depression, anhedonia, not even able to get up from bed, not being able to look after his personal hygiene, has got nihilistic negative thoughts, he has got depression, anxiety disorders, particularly PTSD. So the criterion of PTSD exists or pre-exists. So I've given an example. If the criterion for PTSD exists or pre-exists before the onset of the new stressor, the diagnosis or adjustment disorder should not be superimposed on the previous disorder. This is legally wrong. It can be challenged. That how are you going to say, it can be frowned upon by insurers, that you are basically telling that the patient had PTSD before, and now the patient has got a superimposed adjustment disorder. It does not really follow the DSM. Somewhere, actually, we need to follow the DSM. We need to follow the Bible, because otherwise we will find ourselves difficult in court. Okay. So criterion D, and this is something about simple bereavement. This is there in this thing, and this is fairly straightforward criteria. I will not dwell into too much. It's the things are already there on the slide. But the difference between normal bereavement is that there should be a single stressor. I mean, somebody has lost his family member. That's a single stressor. Has that happened at some point in time, some date, some month of the year? And immediately after normal bereavement, it's marked by, and usually in bereavement, reaction, unless it's pathological, it's almost immediate. There's low mood, missing the loved one, feeling overwhelmed, regretful of not doing enough for the person. And recovery is fairly quick. Within 3 to 6 months, I generally use. But if it's any longer than that, then you need to think what's going on. Okay, this is a straightforward criteria. I will not go into this because we will lose the richness of the other part of the presentation, which is there. This can be read by the other participants. So we'll go into the criterion E. Once the stressor or its consequences have terminated, the symptoms should not persist more than additional 6 months. Again, this is easy to determine with one-off stressor, but if the stressor is continuous, it's hard to determine when the 6 months is going to begin, really. In these cases, the maladaptive criteria, which I've used before, and the new normalcy will come handy in sort of understanding where the patient is. And this is a new adaptive normal, which could be in the form of reduced vocational ability, reduced social interaction as compared to pre-morbid level. And this could be the new normal for the patient. When it is global, like social, as I said, look at the number of problems that the patient is having in its maladaptation. If it's global in terms of social, vocational, recreational, interpersonal, relationship, educational, almost everything he ticks the box, the patient is not normal. Patient has not reached a new normal. Patient is still unwell at this point in time. All right. We know that adjustment disorders of various kinds. I'm not going to go into detail. It's there in DSM. It can be read well in the bigger DSM and what it means. But one of the things that I would really talk about is unspecified. And I wonder when adjustment disorder patients complain with suicidal ideations, whether this criteria should be used, because there is nothing under suicide with adjustment disorder or suicidal thoughts as such. Whether you would use conduct, I usually use unspecified. I mentioned clearly that this is happening, and we'll discuss that later in the interview, in the session. This is epidemiology. It's good to know what the epidemiology is in general population, community samples, 2 to 8% in children and adolescents is seen, 12% in the general population, generally in mental health outpatient setting, as many as 50% of the population have experienced specific stressors, so people can come with medical problems. Every second person who comes to a GP clinic has got some or the other problem. It could be a psoriasis, it could be exacerbation of work issues, It could be medical issues and all those things. So individuals from disadvantaged life circumstances experience higher rate of stresses. One of the important things that workover always asks is, doctor, do you think that is there any other stressor that is influencing this patient? People who are poorly attached, who have got attachment traumas, who have got past history of trauma, would adjust to things very poorly, and it must be clearly documented so that you can give proper discounting on the WPI when you calculate. Because pre-morbidly itself, the patient was not coping very well, and there's no point in giving the WPI pre-morbid as 0. And this at least should be, if you're not able to calculate because you don't have a baseline, it's important to actually identify this or acknowledge this, that this patient was sensitive. For example, I saw a patient this morning, the patient was very sensitive. And it was no wonder that he did not cope with the job that he was trying to do. And acknowledging that at least puts you in better stead as compared to somebody who doesn't acknowledge it, because at least the insurer and the other party at least knows that you have been careful actually identifying that this is happening with the patient. So measurement of illness as a stress. Now, this one, I think one of the things that is that stress is a very subjective word. Stress is a word that is used in different ways. Sometimes it refers to environmental stress stimulus, a threat or demand from outside world. The definition lies between various measures, such as social you can use, so this is what I was trying to talk about, social readjustment rating scale or Bedford College life scales. Have a read through them. They've got, social readjustment scale has got 43 criteria there. They have used the demographics, culture, and all those things to reorganize them. We know that death of spouse is the top criteria, and avoidance of school of work is the least of the stressful criteria on this particular rating. And it's important to have that in your mind when you are basically looking at the stressor and the reaction of the patient to it. So if you have got a person who has just lost his job, but is behaving as if he lost his parent or his spouse, then probably he's sensitive to stress, isn't he? He's overreacting than what would be even adjustment disorder probably be giving him, you know? So how long does the adjustment disorder last? This was a topical question, which I said, this is a difficult question to answer, because adjustment disorder are provoked by a newly onset illness and usually resolve within weeks. But slower recovery can take place in chronic illnesses. My rough ballpark is, if my patient, this is my clinical practice, but I'm actually seeing the patient, if the patient has not recovered in 18 months, I would think that I would strongly question my diagnosis, and I would sort of introspect, am I dealing with depression? Am I dealing with some form of depression, probably and following the depression algorithm and following the RANZCP guidelines, and probably trying to work out what's wrong with him, and whether he's got cognitive problem, or he has got neurovegetative problem, or he has got sleep. And I will try to actually categorize him and try to treat him on those lines. If recovery has not occurred, the patients usually develop another mental health disorder, such as a depressive disorder. Accurate data are probably that no more than 10% of the patients develop prolonged adjustment disorder. So that's how low it is. So only 10% of the patients actually develop protracted year after year adjustment disorder. It's very low. That's the literature. If the adjustment disorder, therefore, for a patient is prolonged for nearly 2 years, we consider diagnosis, revisit the criteria, give cultural considerations, but after 18 months, revisit. Alternatively, you can get a second opinion. There's no harm in getting a second opinion if you're not very sure. The etiology, again, I've not gone into details here. I've just put the dot point here. Why do you think that the coping mechanism fail in patients? It's either the demands from whatever is causing the stress may be overwhelming, the resources to cope with stress may be inadequate or missing, coping responses may be ineffective, and this is particularly seen in sensitive individuals. It is difficult to predict who will develop an adjustment disorder, but people with past trauma and sensitive individuals have a higher propensity of developing this disorder than others. This being a repetitive thing. Now comes to the treatment. Look, anything has to have a treatment, and we need to actually discuss a treatment very obviously. While psychological treatment will be mostly in the domain of the psychologist. I mean, we are doctors and we are also therapists, and we should never stop supporting our patients. But medication treatment are the ones because of which patients always almost gravitate to the doctor, because sometimes GPs are nervous about actually treating adjustment disorders, I've seen. Some of the bolder ones will put Lexapro and then send the patient to you. But antidepressants can be effective in the presence of physical and psychological stressors. There is no good evidence to support claims for greater superiority and efficacy of SSRI. So there, in adjustment disorder, we almost see an epidemic of Lexapro or escitalopram that is not really needed. Other medications can be tried depending on the patient's condition. The only advantage for the long-term use of SSRI is their tolerability and may be greater than other drugs, especially in patients with physical disease. The other schools of thoughts are actually anti-medications. Some of the thoughts are that drugs should be used. The other schools of thoughts are that drugs should be used in treatment of adjustment disorder, and pharmacological studies are not conclusive. So there is no conclusion that actually medication should be used at all, and you should just watch and wait. But generally in my clinical practice, I actually use tricyclic antidepressants as well, including amitriptyline and duloxetine, depending upon the cause of the adjustment disorder. If the cause of the adjustment disorder is chronic pain and insomnia, I would not think about an SSRI. I would use one of these two medications. They are much more effective and much more beneficial. NDEF for sleep and pain, and duloxetine for straightforward pain problems. Psychological treatment is mostly cognitive behavioral therapy, trying to reorganize, restructure the thoughts, giving the patient hope and optimism, helping the patient understand that stress will go away. It's not there to stay. Or if the stress is not something that can be removed, then probably helping him to cope with his circumstances and situation and helping him to reach the new normal, which we have discussed under the maladaptive states. And interpersonal therapy is very important. Understanding the loss comes under interpersonal therapy. Brief dynamic therapy can be important, especially if there are past history of trauma and past history of issues which are probably affecting him. Identifying cases is the most important challenge. Sometimes simple K10 at GP level might help, but there are several self-report questionnaires which may help. There is a scale on the internet, which is called ADNM. Most people would have seen it. It's a 20-point questionnaire, and it has got 18 stressful events and in human beings' life. It's a snapshot tool which can be quickly actually administered in your clinic, or you can educate your practice nurse who can do this. And it's important. Education, training is the most important in identifying adjustment disorder. Most of these screening tools can be provided in a primary care clinic. Nurses can be equipped, they can be well educated, just as they do Edinburgh postnatal depression scale. This is as simple as that. Prevention, any illness comes with a package of prevention. There are two more major broad approaches. One is education. Knowing about adjustment disorder, knowing that it exists, knowing that it is not a disorder that can be brushed away, knowing that it has got treatment, leaving the patient with hope and optimism. Be vigilant about the patient's cultural needs, being vigilant that everything that the patient is responding to the stress may not be pathologic. Try to look at the cluster of problems that the patient is experiencing than one social or work-related problem. Like work avoidance can just not be a criteria for adjustment disorder. There needs to be other things. That's what education is all about. And provision of support, which can take in various forms like self-help groups, volunteer visiting, professional support workers. If you look at the Victorian Royal Commission, the whole thing is about finding the middle zone. It's about having the strategies and policies and procedures and prioritization, adaptation of helping these patients who are sick, but not enough to become hospital material, but they are not enough to actually go to the GP, and helping them and supporting them, and so that they are safely transferred over to the private clinician. And it's important that who deals with the stress. Having adjustment disorder is slowly becoming an expert topic. I mean, I cannot really counsel somebody who probably has got AIDS, acquired immunodeficiency syndrome, because I have not suffered from it. Somebody who has got, this is where the lived experience comes in. Somebody who has had a stroke himself or epilepsy himself and has been controlled would be a better person to actually relate to such person, and having cosmopolitan people in your team is important in supporting these patients. Now, expanding on psychological responses to adjustment disorder. Now, everybody would have heard about a step care model. Step care model starts from step 1 in GP and primary care level to step 5, which is inpatient and crisis team. Adjustment disorder can need anywhere between step 1 to step 5. So do not underestimate this disorder. It can basically consume the whole sector of the step care model. So it's there in websites, but do not hesitate if the patient is risky to send them to the hospital. Now, suicidal behavior, I think I'm just not going to actually inundate my colleagues with information, but I thought that I'm just going to pick up, I'm just mindful of the time as well. So we'll go into the last paragraph of this, last paragraph. We know that adjustment disorder actually presents with suicidal behavior. We have all experienced this clinically. We have seen patients whom we have diagnosed with adjustment disorder who have cut themselves, taken overdose, and all those things. Adjustment disorder should not be ignored, that it cannot cause DSH or self-harm. And there was a DSM-4 work group which stated that we have got subtypes of adjustment disorder. One of the things that the work group said was that we're going to have adjustment disorder with suicide and self-harm. Unfortunately, it's not there in DSM. But this is where, when I basically discussed the criteria in the beginning, that unspecified one, I put the suicidal ones under this and mention that they are self-harm and suicide. And the problem with actually labeling, when the reason, and there is a reason why this work group was not able to actually label it, because they felt that because adjustment disorder is supposed to use lower resources, patients who have got an algorithmic diagnosis like depression, PTSD, major affective disorders will get ignored. And people will say, oh, this patient has got adjustment disorder and probably he's self-harming. So basically, let's give the patient less support. So that's probably the reason why this did not get that much of window, that did not get that much of traction. But I think one of the concerns was that patients who had major mental illness and suicidal behavior may get ignored, may get sort of turfed away if adjustment disorder with suicide came. But at the same time, it's a reality that patients actually terminate their life even with adjustment disorder diagnosis. And many coroner's reports will be sort of witness to this. Adjustment disorder patients are found to be among the more common recipients of deliberate self-harm diagnosis, with majority of them involving self-poisoning. Overdosing in adjustment disorder is very high. They would usually not be cutting episodes, or sort of other episodes like gassing and all those things will not be seen. Thus, deliberate self-harm is more common in adjustment disorder patients. Suicidal behavior, when patients have got adjustment disorder with depressed mood, when they are basically feeling low consistently, other kinds of self-harm can come in, but most commonly poisoning is seen. With suicidal behavior and self-harming tendencies, it was important to actually work on the stressor and to work on the step model of care and identifying where the patient's risk is, whether the patient is safe with the GP, whether the patient is safe with you, whether you should see the patient more frequently, or whether you should actually send the patient for tertiary care, for a follow-up and checkup. Okay, look, that finishes. I know I sort of zoomed past because there was so much there, and I thought that I would bring it all up. And I'm happy to actually, obviously the presentation will be shared. It's difficult to talk through everything, but I've put it all there so that people can understand. This is from textbooks, journals, my understanding, clinical experience. And Michelle, over to you.
That was incredible. Thank you so much. I learned an awful lot myself just listening to that. I'm just going to try and reclaim host. People, do you have some questions that you would like to ask Dr. Dasgupta? Please feel free to either. Sorry, Matt.
It's Matt Paul here. So thank you very much for the presentation. I'm just interested. Psychiatry has a bit of a problem with diagnostic reliability. And so we're often confronted with medico-legal reports from different parties, including psychiatrists with multiple different diagnoses. And we don't, understanding that there is this diagnostic uncertainty and poor reliability, we don't have much confidence that one psychiatrist's diagnosis is more sound than another's. So, I mean, how do you address that when you see patients? How do you allow the reader of your reports to be more certain that the diagnosis is the one that you have assigned, especially in relation to adjustment disorder? And the other question I had is around prevention. Is there any evidence that prevention actually works, it reduces the incidence? Sorry, two questions, both tricky, sorry.
No, that's all right. I'll try my best. Okay, so the issue with adjustment disorder is that gathering collateral and reading through the GP lines and probably actually making that effort to pick up the phone and asking the primary health provider or asking the family member to actually come in gives you more reliability. So the reliability of your diagnosis is based on reliability of the data. If you have just questioned the patient and you have diagnosed the patient with depression, then probably, I mean, there will be something called a interviewer bias, and you would basically sort of bend towards the patient to help. And it depends on which context you're using. I mean, if you're a work cover psychiatrist, you will be more critical, you'll be sharper. If you're working, but having a collateral always helps you in actually increasing your sharpness of diagnosis, because you've got more data actually sort of supporting you that the patient is basically failing across different domains. The wife will tell you that he was doing washing, he was doing things, he was doing shopping, he was taking kids, everything has fallen apart. Coming to the depression, whether distinguishing between depression and this thing, one of the things that I look at is the stressor and the patient's previous coping mechanisms. And if the patient has been coping very well, and suddenly if he has crashed, then probably adjustment disorder is something that you need to actually diagnose with caution, and probably give the patient a little bit more time and probably a few more sessions to actually identify that whether you're dealing with adjustment disorder. But if the patient has been historically very sensitive, then you know that the person will not cope with the kind of stressor that he has. It's a probability of adjustment disorder is much more higher. And using multiple diagnoses, as you heard in my presentation, Matt, I think the reliability decreases when people actually use something that does not align with DSM, like using PTSD and adjustment disorder together, or major depression and adjustment disorder together. Well, no. Is the patient depressed, or is the patient having adjustment disorder? If you are going to say major depression and adjustment disorder, you want to say that previous major depression has actually healed, and he was completely normal, and now he is on a new tangent to develop another episode of depression. If he had previous episode of depression, and if he is sort of started decompensating, probably he is not having adjustment disorder, probably he is having another episode. The patient has had PTSD, which led to the injury, and the patient has now decompensated after a management sort of intervention. It is an exacerbation of stress, which is not related to the index injury, but still an exacerbation of PTSD. So that way your reliability increases. And regarding the prevention, education of the primary health clinician, having a knowledge of the stepped approach quickly, being able to go through that that list very quickly, and it's all risk driven. If the patient is not coping, patient is not if he has decompensated in terms of most of his vocational and social functioning, probably it's a good idea to think what time you would like to actually hospitalize the patient, and that's prevention, isn't it? That's prevention of further morbidity. And if your practice nurse was aware of adjustment disorder, and if she knew that which were the stressors which would lead to heightened response in patients, and they were just aware of the social adjustment scale or the Bedford scale, they would immediately identify that this is a significant stressor. Probably a 78-year-old man had a 30-year-old relationship or 50-year-old relationship with his wife, and his wife has suddenly died. This patient is going to develop adjustment disorder now, or probably he's going to get depressed, because the loss of spouse is on the top of the list, and especially after 50 years relationship. So prevention can only come with knowledge that what basically is adjustment disorder, how is it diagnosed, how it can be differentiated. That adjustment disorder can come with a package of suicide. It's mostly overdosing. You cannot have adjustment disorder for years after years. You cannot do double diagnosis of adjustment disorder. So that will make the diagnosis more crispy, more reliable, more specific, and probably it will assist the population, and you will be able to prevent morbidity by preventing hospitalization when needed, but you will have to use hospitals if necessary. Okay.
Wow. That was amazing. Thank you so much, Dr. Dasgupta. There's a lot of information in there, but really, really well delivered. It was interesting to me to hear what you were saying about the definitions in the DSM and how you have to be so mindful of those in a report. And I think that was really important to everybody. Thank you, everybody, for joining us for this. Thank you once again, Dr. Rupak Dasgupta, for giving us your time and the benefit of your amazing experience. Everybody, the recording and the slides will be available within the next couple of days. If you have subscribed with your email, they will be sent to you. And Dr. Dasgupta is available to book for IME assessments through MAG. And if you would like to know any more about him, please feel free to contact me. Thank you all and have a wonderful rest of the day. And I hope you will enjoy the long weekend coming up. Thank you very much.
Thank you, Michelle. Thanks, everyone, for having me.
Bye.